Now, nearly 100% of global maternal deaths occur in developing countries, with more than half of these deaths occurring in sub-Saharan Africa. Nigeria's current maternal mortality rate currently stands at 512 deaths per 100,000 live births, one of the highest in the world. According to the World Health Organization, a Nigerian woman has a 1 in 12 lifetime risk of dying during pregnancy, childbirth, or postpartum or post-abortion, whereas in the most developed countries, the lifetime risk is 1 in 4,900. It says the high number of maternal deaths in some parts of the world reflects inequities in access to health services and highlights the gap between the rich and the poor. Joining me now to discuss is the Managing Director, Nigeria Health Watch, Vivian Ihekwazu. Good morning. Thank you for joining us on TVC Breakfast.
Good morning. Thank you for inviting me on your show.
You're welcome. Now, when you look at all of these statistics that we have outlined, you wonder, because we have seen efforts on the side of government and even the private sector to address these issues, and you wonder what really is the missing gap that such that we are not seeing as much results in terms of effort being put in place.
Thank you for that question. I think you started off by presenting some statistics on the high levels of maternal mortality in Nigeria, 512 per 100,000 live births. The SDG 3 goals has set a target by 2030 that it should be no less than 70 per 100,000 live births. So we are really far off from that 2030 target. And there are definitely missing gaps into understanding why women are dying in Nigeria. 20% of maternal mortality in the world is in Nigeria. We're the second highest contributor of maternal mortality behind India. And if you think of the proportions of our population, like 200 million compared to over 1 billion, it shows you that there is still a lot of work to do, and the issue of maternal mortality has not received enough prominence if you look at the large numbers. When you look at how women access child health and healthcare in Nigeria, you see that when women give birth, only 43% of women in Nigeria give birth with a skilled birth attendant in a health facility, which means there's a significant number of women who are giving birth in communities. And we're health engagement and advocacy. We worked with a consortium which included EPI-Afrique and Africare, and we conducted a community-informed maternal death review to understand why women were dying in the communities, because, as I mentioned, that's where a large proportion of women are dying. And over this one-year review, which happened between 2019 and 2020, we worked across the 6 geopolitical zones, looking at one state representing each political zone. And we worked in 2 communities per zone, and really tried to understand the reasons why women were dying. And what we found was, when women die in communities, there is no accountability mechanism that actually does the necessary investigation into why they're dying. Health facilities have a system called the Maternal Perinatal Death Survey and Response, which is supposed to, at the facility level, document and understand the woman's journey through the health facility, understand why she has died. So if you think about it, if the majority of women are dying in communities and there has been no systematic attempt
to look into why
women are dying,
is happening,
that shows you the gap that we are missing. Through our review, we found that a lot of women die in communities from postpartum hemorrhage, excessive bleeding. And when that happens, there is no mechanism for them to, at that point in time, get to a health facility. And their deaths are not recorded or accounted for. So for that reason, there are no lessons learned. And the communities bury them. And unfortunately, we have this practice in Nigeria where we just almost move on. But, you know, we have to move past that at this stage. So that was the importance of actually, as you mentioned, where is that missing gap? So this community-informed maternal death review, which was supported by MSD. You know, MSD is an initiative that is looking to create a world where no woman dies giving life. So with the support of that project, we were able to really speak to community members, monitor on a monthly basis women that were dying.
All right.
And after that review, we were able to get a better understanding and think through the journey and some of the challenges that women face. We looked, as mentioned, in 6 geopolitical and of each area.
And that is where the collaboration between the private sector and perhaps the government comes to play, where you get this information and perhaps engage government to perhaps look in this direction, that areas like this has to be addressed. Talk to us from that window, what the level of engagement or collaboration with government has been at addressing these issues.
In terms of engaging government in addressing the issue of maternal death, because, as I mentioned, there hasn't been any review or documentation on why women were dying, there is no evidence for them to actually know what next to do. So through this maternal death review we conducted, we gave evidence to government and show them the challenges that women face across different states. I'll give you an example. One of the states we worked in was Bayelsa. It's a riverine area. When women are in labor, if they're far from a healthcare facility, they're not able to get to it. The community we worked in, the nearest primary healthcare center needs to be accessed with a boat. So without that support and without the ability to get to a primary healthcare facility, they're not able to give birth safely.
Yes.
Another state we worked in was Niger State. Many women are not able to access primary healthcare centers because they're non-existent. And so in the communities, one of the main means that they get care is with traditional birth attendants.
Now, that brings me to the next question, because that is the person a lot of communities, respond to and believe in their efforts. Are we looking to perhaps train the traditional birth attendants, which some persons have said perhaps that could be another way around addressing this issue, train them on how to handle issues such as where there is hemorrhage or postpartum bleeding?
Yes. I mean, traditional birth attendants, there are many different views as to whether to bring them into the healthcare system or whether to exclude them because they are unskilled. And a lot of deaths happen in the homes of traditional birth attendants. However, the challenge is we know we have a deficit, we have a shortage in skilled workers. So it's important to bring those traditional birth attendants and include them in the care of the women, train them, but also train them to know the danger signs of pregnancy. So if a woman is with them, because they have a very close relationship with these women, they're in the communities, they have a long-term, they've helped many women, let me put it that way, give birth. So many women go to them for, some because it's financial and some are because they have that close relationship. But we need to bring the traditional birth attendants into the health system and train them to know when to take the woman to a healthcare facility when it's clear that they've reached a limit where they can no longer provide the necessary care and enable her to deliver safely.
Now, another issue is the fact that some women cannot access perhaps what is called, try to prevent pregnancies. Some do not have their rights over their bodies. Let's say religion, cultural practices. We also have child marriages. All of these factors. Now, the aspect of creating awareness, education, advocacy. How are we driving that towards perhaps these communities where all of this also happen?
I think in terms of how do we ensure that women have access to health care and there's advocacy and training, one of the critical things that women do when they're pregnant is attend antenatal. And that is a critical area where you reach the woman at a point where she needs to understand about her birth, about
the changes in her body.
Yes. So when we find that 67% of women attend at least one antenatal class, but by the time it comes to giving birth, many give birth in homes. Like in some of the northern Nigerian states, we found that whilst many women attend antenatal classes, when it comes to giving birth, they go and give birth in the communities, and there are diverse reasons for it. Some it's financial, but some it's also cultural, in that men are not comfortable with their wives in health facilities giving birth because they're male health workers. So for them, they're uncomfortable. There's that aspect of it. And then there's also the cultural aspect of not really understanding why you give birth in a health facility. There's that cultural tradition of giving birth in homes with a traditional birth attendant. And in Lagos, we worked in 2 communities, and we find that many women give birth in faith-based centers. When we were doing the review, there was a story of a young girl. She was 29 years old. She went into labor. Her mother took her to a faith-based center. She started bleeding, and they started praying with her rather than taking her to a health facility.
Really?
Sadly, she passed away. And we find that this happens in some states because there is, as you mentioned, cultural practices, we're a very religious country, and cultural practices often supersede what people understand. And health education is a critical gap that we have definitely identified. And so that's why we feel that at the community level, there needs to be more education, more training. And the training doesn't just come from the women. The training is also the fathers, the religious leaders.
They have a role here too.
They are very, very important stakeholders. So involving all those stakeholders in the communities, providing health education to them, understanding why it is important for women to go to a health facility to give birth is very important. We understand and respect religion and tradition, but it must not supersede health education and good health advice.
So perhaps we might have to be looking at community communicators such as perhaps traditional rulers and faith-based leaders within such communities to engage the people. Are we looking at that?
Absolutely. Part of the findings we found was we need to better engage those community leaders and traditional fathers because they have a large influence on the fathers. Like we found that in some states, a woman has to get permission from her husband before she goes to give birth. And when we look at some of the delays in pregnancy that leads to death, the first delay is actually knowing when to go to health facility. So women may be in labor, but before they're able to leave the home, they have to ask their husband. And imagine a situation where a husband is not at home. The woman has to wait. Sometimes they may have to ask a mother-in-law. But the fact that they have to ask a husband means he's a critical voice in the safe delivery of a pregnant woman. Yes.
So as it stands now, if we are to begin to address all of these issues that you have pointed out, where do we begin? What is that critical aspect, the critical game changer, if I may use the word, where we can begin from?
Okay, I think if we look at where women are giving birth, if most women are giving birth in communities, 43% are giving birth with a skilled birth attendant in the health facility. We are critically not looking at community deaths. We have to ensure that community deaths are recorded, are monitored, and there is a response mechanism to address why are people dying in communities. Some of it could be a woman is in labor and she can't even get to a health facility. That's what we call one of the second delay, actually reaching a health facility. So in all the different states we worked in, the reasons for women dying were quite diverse.
Absolutely.
But the leading cause of death was postpartum hemorrhage, which shows that there is a critical need for women.
And this is preventable, isn't it?
Postpartum hemorrhage is preventable if a woman is given uterotonic, which enables her to stop bleeding. So that's only really administered in a health facility. And even in health facility, we do have challenges with the actual uterotonic in terms of quality, but that's a wider issue. But the immediate reason women are dying is excessive bleeding. And if we say that there are no health facilities for the women to access, or she has challenges reaching them, then we know that we have to address those issues quite critically. But the starting point is really working within the communities in advocacy, ensuring that women go to health facilities to give birth. And when they die in the communities, those deaths need to be monitored and fed into the state monitoring system to understand why women are dying. And it has to be investigated and actual policies put in place to address some of those critical gaps.
But you know how it is in Nigeria, which a lot of persons have talked about or raised concerns about in terms of our data, how we gather our data and also handle it so that we can channel it to address issues such as this?
I think, if at the community level, like Lagos actually is one of the states that actually has been fully implementing, or at least more than other states, the facility-based monitoring of deaths. So going through that process on a monthly basis, investigating and actually looking to drive action. But the community remains the missing gap. So if we don't have that data, then you can't do anything. Without data, you're working blind. So we need to ensure, and the statistics just tells you the grave situation. Like if you look between 2005 and 2015, about 600,000 women died in childbirth. And we look at those numbers and they seem abstract. But behind those numbers are mothers, sisters, daughters. And, we look at who does maternal mortality affect? All of us. I think the hand-wringing and the thinking, what are the solutions? We have to do something about it. If 20% of deaths, maternal mortality globally, is in Nigeria, that statistics is a rallying cry that we have to address it and look at where, as you mentioned at the beginning, where are the gaps that we are not looking. And if deaths are occurring in communities and they're not being recorded, solutions looked into, then we're missing a huge number of deaths that could be prevented if something was done about them.
Very important. We must leave the conversation here now. Thank you so much for your time on the program, Vivian Ihekwazu, the Director, Nigeria Health Watch. Thank you for your time.